Good afternoon and welcome to the second edition of the Sunday Times Live Dialogues, where we aim to provide readers with insights into the most burning issues facing the country. My name is Nikki Gulesh, and I am the Assistant Editor for Investigations and Projects at the Sunday Times. My co-host is Tanya Faber. She's a Senior Science Writer for both Sunday Times and Times Live. So tomorrow marks 6 months. Exactly 6 months since South Africa recorded its first case of infection of what began as a mysterious virus in a wet market in Wuhan, China. So here we are a half a year later, and we're living a completely new reality. The term COVID-19 didn't even exist until February, and now it has reconfigured every single aspect of our lives. As of last night, the country has registered 633,015 infections, nearly 4 million tests have been conducted, and 14,563 people have sadly died, although this number is likely higher. We have with us today some of the country's top experts from different disciplines who are going to share their insights into the past, present, and future of COVID-19 and the disease and the epidemic. So what we do know about COVID-19 and the virus that causes it is that it emerged in Wuhan and has spread to the rest of the world, bar 3 countries. We know it's transmitted in water droplets and that it can remain in the air, particularly in confined spaces, as well as on surfaces. We also know that infected people can range from the asymptomatic to the very critically ill. But there's still a lot we don't know about the virus, including whether herd immunity is possible, if you can get the disease again once you've had it once, and whether or not climate plays any role in transmission. So today we want to conduct a post-mortem on the outbreak in South Africa and our health response to it. We also want to find out what's happening next so we can plan our lives. Our expert panel are going to help us to answer these questions. Over to you, Tanya, to introduce them, please.
Thanks, Nikki. We have an amazing panel lined up today. Super proud to be speaking to these brilliant, intelligent people. First, we have Prof. Shabir Madi, who's a professor of vaccinology, and he is director of the South African Medical Research Council's Vaccine and Infectious Diseases Analytical Research Unit. We also have Prof. Gesine Meyer-Roth, a medical doctor and health economist. She's an associate prof at the Department of Global Health at Boston in the US, and she lives in Johannesburg, where she works at the Health Economics and Epidemiology Research Office. She is part of the National COVID-19 Modeling Consortium. Then we also are very lucky to have Prof. Hlonipha Mokoena, who's a historian from the Wits Institute for Social and Economic Research. And then last but certainly not least, we have Dr. Nicholas Crisp. He's a public medicine specialist and consultant for the Department of Health, who was deployed to the Western Cape to oversee the department's response to the pandemic in that province. So welcome to all our panelists. We're going to kick off now with our very first round of questions. So we're going to dive straight in. And I'm going to first be speaking to you, Dr. Crisp. Let's begin with you for an opening statement. So the government was widely praised around the world for our response to COVID-19, including by the World Health Organization, for locking the country down when we did. But it has also been criticized for failing to take full advantage of that preparation time in the early lockdown phase that we were given. So how did the health department manage the epidemic?
Tanya, thanks very much. Well, I think in some respects quite well, and in other respects there have been failings, which I think are widely reported and acknowledged in the media. And the question was, how much have we learned from what we didn't do well? So we've learned a lot about service delivery. We've improved infrastructure in most provinces, and some of that infrastructure in particular has been around oxygen supply. We've learned about staffing issues, which were not particularly well managed prior to the epidemic. I think in terms of health products, although there have been widely reported abuse of PPEs, we have largely succeeded in having sufficient PPE. We had huge difficulties with data and data management in the beginning of the epidemic and sharing data between provinces, trying to understand what was going on across the country. And that is generally way better now between the NICD, the National Institute for Communicable Diseases, and the provinces. And in terms of governance, everybody was running around trying to respond without too much guidance in the early days, and it has systematically got better. And there's more interprovincial coordination now than there was in the beginning. So I think we had some shaky starts in places, and we've had some bad responses, but on the whole, it has been the response has been relatively good under the circumstances, I believe.
Great. Thank you so much for your insights, Dr. Crisp. Prof. Maddy, I'd like to turn to you now. I mean, this is a field that you've been involved in for so long, but obviously in some ways, a zoonotic disease or a pandemic of this nature catches us off guard. So what do you think, if we think about it constructively, what could the health department have done better? For example, a lot of the spotlight has fallen on the Eastern Cape for what we consider a subpar response. So what do you think the health department could have done better?
So thank you, Tanya. So just to go back to what Nikki said, we're not doing a post-mortem of COVID-19 because we're far away from the end of this particular pandemic. I think it would be premature to be doing a post-mortem. But what could have Department of Health done better? I think the major learning lesson from this pandemic and looking at South Africa's experience, as well as a global experience, is that this sort of unmasks the absence of having an adequate pandemic preparedness plan in place. So the countries that have been best equipped and that have best managed the pandemic are those countries that actually had a pandemic plan in place, and they were able to implement it because of functional healthcare systems. What we've seen in South Africa is really an unmasking in terms of the lack of resilience in our healthcare systems. And as Nicholas has mentioned, there's a number of shortcomings that were identified, but those are not issues that have been identified in the past few months. Those have been issues that have been existent for years. You cite the example of the Eastern Cape, one of the provinces with probably the most fragile healthcare systems. And the pandemic, all that it's done is sort of unmasked deficiencies in the health system itself. In terms of what else government has done or should have done differently, it's difficult to sort of quantify because South Africa, unfortunately, has got a very federal type of a system in terms of its healthcare delivery. And that is, in fact, one of the things that we need to reflect on, especially in the midst of a pandemic. Is that the correct sort of approach to be taking in terms of trying to manage the pandemic? You need to have much more centralized coordination in terms of what's being done rather than allowing for provinces to decide what to do. And I think that's been another important, possibly a deficit in terms of our approach. Other than that, there are some factors which, unfortunately, were completely external to government, which the NHLS needs to take responsibility for. And in particular, the issue of inadequate capacity and capability to scale up testing when it was required the most. So when we went into a level 5 lockdown, there were a number of reasons for doing so. One of which was trying to contain transmission of the spread of the virus in a community. But in the absence of being able to test at scale, that was simply going to fail. And we failed when it came to trying to contain transmission of the virus in the community. Last but not least, I think what's critical, and I don't think that lesson has been learned up to now, is that even though there's probably more data sharing between a province and national department, unfortunately, there isn't adequate data sharing when it comes to data sharing with academia. And that is absolutely essential if you're wanting academia to play a role in terms of informing what needs to happen. So I think there needs to be greater transparency in terms of access to data to the public, to academia, so that informed decisions can be made and informed recommendations can be made.
Thank you so much for your insights, Prof. Maddy. I think Prof. Mayor Roth can now speak to us about, this has been the first wave of what Prof. Maddy has consistently said is going to be something that we get several waves of, and it's not going away anytime soon. So, Prof. Mayor Roth, maybe you can just talk to us about the big scary figures that were initially predicted and didn't always come to pass. And what did the National COVID-19 Modeling Consortium initially predict the death toll would be? I know different modelers came up with different figures, so maybe you can speak specifically about your consortium. And then also maybe you can just share with us how you go about modeling an epidemic and what the variables are, because, I think for the public, it's quite a difficult thing to try and untangle.
Yes, absolutely. Thank you. I think modeling has gotten a lot of flack lately. some probably quite for good reasons, others not so much. I always think as modeling that none of us gets through a day without. If you decide in the morning what clothes to put on, whether to trust the weather forecast, if you're deciding if your kid will sleep through the night after weeks of not, if you're deciding whether or not to start planning for your December holidays this year, you will have to make a number of assumptions based on data. And that is exactly what we do as modelers, only that we use probably quite a bit more mathematics and a little less intuition than what we use in a day-to-day situation. What's important when you model COVID is that there isn't perfect data on any of the factors that you need. So essentially, you have to make a decision firstly which type of model to use. Almost all infectious disease modelers at the beginning of the year landed with a very standard model. It's called an SEIR model, a susceptible, exposed, infected, recovered model, which basically just moves people in a population through those states, depending on certain assumptions about how many of them will be susceptible, how many of them will then become exposed, will get infected, what happens to those that are infected, how severe the disease will be for them, how many end up in hospitals, how many end up in ICU units, and then how many of them recover, and of course also eventually what proportion goes on to die, unfortunately. So that is a standard modeling system which we use, which has actually put us in quite good stead, especially given the uncertainty in each of the 4 or 5 main inputs, which is how many people does everyone who has the disease infect, how many people have the disease quite severely. We assume that it was only a very small proportion, 4% would end up in hospital, and only a quarter of those, 1% of all cases, would need intensive care. How many people would die, especially from having more severe disease? How long would they stay in hospital? One of the big unknowns, which drove a lot of our assumptions about how many beds we'd need, and how many risk factors would drive each of those. So what would be, instead of just having one average rate, would be the rates applying to different parts of the population. Since we all know we didn't have perfect data on cases, which would have told us something about transmission, perfect data on deaths, or perfect data even on how many hospital beds were full at any given stage, we did have to make a lot of assumptions. At the beginning, that was based on data from elsewhere. As we went along, we were lucky to have access to the data from collected by the Department of Health and the NICD at any given stage. So we did update our models on essentially a weekly basis. This has not been in front of the public, and that is probably one aspect that I personally feel we might have done better on, mostly for the reasons that we did all of this as the modeling consortium in our spare time. And the core group of modelers consists of people who are running research groups on the side and funded to do something else. So that was probably something we should have or would have optimally been able to do. But as Dr. Crisp and others can attest, all those numbers were regularly put through to the Department of Health in order for them to do something with it. And I'll end with saying that when it comes to our death projections, and we take no pride and absolutely no joy in this, we will probably end up being quite close to the 40,000 deaths if you include the excess death that we projected in mid-May.
Okay, thank you so much, Prof, for those amazing insights. Very, very interesting. And I think, Prof. Mokoena, the nature of the research that you do and the work that you do, you are a very multidisciplinary person. So you look at something like this through various lenses. And we're living in a country that's one of the most unequal societies on earth. So obviously a pandemic like this exposes and exacerbates some of the sort of racial and class fault lines. So maybe you can talk to us about how different races and classes in South Africa actually handled or made sense of the lockdown. And then also maybe you can talk about how effective government has been in managing the outbreak amid these ongoing challenges.
Tanya, thank you so much for your questions, and thank you for bringing me onto this panel. And I mean, as you've heard from the previous speakers, the people who are the experts in what I'd call the technical management of the disease. As a country, we haven't done as badly as people predicted we would I think the African continent in general has in fact not been the worst edge of the pandemic. And again, it's still to be seen whether the figures are correct, whether we perhaps are on the tail end of quite a long pandemic, etc., etc. So the unfair part about being a social scientist or a historian is that you have to speak about things that don't involve numbers. You don't have numbers, you don't have figures to predict. So how well people cope. I think when the pandemic first started, there was just an assumption that the fault line will be between the haves and the have-nots. But I actually think over the last couple of months, it has become clear that actually that those are not the fault lines. The fault lines are actually more at the level of mental health issues. So of course you have people who can't go to work. Of course you have people who can't earn a living. Of course you have people who can't feed themselves because they have nowhere to go and work. But I think one of the things that is becoming clear is that there seems to be an emerging despair that is linked to many of these pandemics around the world and other kind of seismic, I think you called it a seismic event in one of your questions, other seismic and catastrophic events, where it's not so much that people are poor or rich, it's simply that they give up. They think of it as, this is the end of the world, this is the end of history. And the other alternative is for people to immediately veer towards conspiracy theory. And this is also the other part where there's no expertise in that field. There's no way to quantify the extent to which people are actually not at all even interested in a rational argument, or even they are interested in rational figures. They're just interested in who is the person who caused this disease. You know, this is the whole point of conspiracy theories, is to sort of nail a conspirator of some kind, or conspirators of some kind. So as a social scientist and a historian, those are the things that fascinate me the most about pandemics. It's not so much the figures, you know, it's not casualties and survivors, the extent to which science has buoyed us or let us down. It's really the ways in which we are experiencing almost a successive kind of propulsion of what people used to call paradigm shifts, you know, where you think you know how hospitals work, or you think you know how medicine works, or you think you know how science works. And then all of a sudden you have to change all those paradigms, but you have to do it within a very quick period of time. So I would say that, going back to the way that you framed the question, the issue is not so much about the inequalities in the country. It's the fact that the pandemic has exacerbated the inequalities, but also introduced a new set of inequalities, and those have to do with mental health issues, where I think that's one of the things that nobody would have prepared for. People were originally sort of preparing for 21 days. And then it was the lockdown was extended, and it was extended. And so that kind of impact on people's psychological well-being may well be a new fault line that we never ever imagined when the pandemic started. So I think that's how I would sort of sum up what I would call the historical or social science perspective, is that the figures don't really tell you how much is going on in terms of the psychological impact on people's understanding of their well-being. So the subjective experience of well-being, rather than the objective figures that tell you how well or how badly our hospitals or our medical professionals are doing. So for now, I'm just going to pause there, but I think that would be, for me, the starting point, is to really think about the fault line that has been created by mental health issues, and this sort of almost like a global sort of glacial sensation of despair, in which everywhere in the world, people seem to be just giving up. And in that giving up and that acting out of that despair, you are seeing quite interesting repercussions across the world.
You're right, Prof. Mokoena. Every one of us, I'm sure, knows a conspiracy theorist, or if not in person, then on Facebook at least. If I can go to round two, Prof. Mahdi, as infection numbers decrease, which we're seeing now, in your view, are we over the peak? And which provinces have peaked and which have yet to peak? What are you expecting in terms of the numbers? Can you unmute yourself, Prof?
Sorry. So yes, the infection, the number of newly diagnosed cases is on a decline, but I think there's a context to that. Firstly, the number of tests that are being currently done is roughly about 20,000 per day, as opposed to roughly about 45 to 50,000 per day at the time of the peak. So that itself could be contributing to a decline in terms of numbers. But at the same time, the positivity rate, the percentage of tests that are done that turn out to be positive, has declined from 27% to under 15%, which is a good thing, because it means that there certainly is a reduction in terms of community transmission of the virus, but it's still above the threshold of 5%, which is sort of a comfort zone. So we're wanting the positivity rate to be under 5% before we say that we pretty much are sort of controlled in terms of community transmission. And we are a bit away from that at this point in time. So I think the numbers itself is sort of could be misleading in terms of the true number of people that are being infected, even at this point. That being said, the indications across all of the provinces is that all of the provinces are somewhat on a downward trajectory. Some provinces more advanced than others, as an example, the Western Cape and Gauteng, whereas the Free State, as an example, it has probably passed its peak, but it's at an earlier stage in terms of the downward trajectory. So it does differ between provinces, and probably even within provinces, there are differences depending on density of population in different districts within the provinces.
And Dr. Crisp, what did we learn from the Western Cape peak that was critical to managing the situation in other provinces? Because the Western Cape was pretty much the first to go through a big deluge of infections.
Yes, I mean, they were at the spearhead of learning this unknown. As we heard from Gesine, there was, we were still working with figures and trying to understand what the impact was going to be. So we didn't know how many additional beds to provide for, and we didn't know exactly what the spillover was going to be. There was also, as the community transmission picked up, you try and isolate people from communities. But we heard also from Prof. Mokoena how people respond in communities, and in the informal settlements where we were expecting to see large numbers, people did not want to leave their homes. Even when they were offered 3- and 4-star hotels to go into, to get out of the brunt, or either to be isolated and protect the people around them, or to go into quarantine because they had, comorbidities and were at risk, they refused to move because they knew that when they came back, either their goods would be stolen or their house would be occupied, or for whatever other reasons. So there were a whole lot of social things that we learned about community behavior, and that you can't just as a health practitioner or as a government or as a local councillor anticipate and sort of decree how people are going to behave. And the Western Cape was on a very steep learning curve. And I must say, across the board, all the councillors at local government level, all the MECs and the Premier did extremely well to mobilize people. The National Minister, the Deputy Minister, other ministers all went to try and lend their hand. And I was asked to go and help the head of department and the department there with some aspects of their response. So we were learning every day something completely new on how to organize services, how to mobilize communities, how to respond to the clinical care. And we were anticipating that not only would the CTICC and what they call the R300, the other bigger facility that was being built for, as a field hospital, we thought they were going to fill up and we were going to need more beds. So we were preparing with the private sector. So what we learned in the Western Cape is how to work much more closely with the private sector. We learned the dynamics of the private sector, which are totally different from the public sector. We learned about clinical guidelines, which were being developed in a National Ministerial Advisory Committee, and how those impact on both the private and the public sector and their approach to caring for patients, and so on. There were many clinical lessons that were being learned around oxygen, around proning patients, etc., etc. And the Western Cape was at the forefront of that in the country. And I must say, people rallied around and really did help them to think things through and to put the necessary measures in place. It was a huge learning curve that benefited the rest of the country. Thanks.
And Prof. Myrath, are our COVID-19 death figures accurate? We've heard a lot about excess deaths. I mean, people who have passed away at home, not necessarily in a hospital, where the testing hasn't been forthcoming. Do we know if the excess death figures are COVID related, or what is your view?
So it's really hard to say how much of that is COVID, actual COVID cases. How much of it is because of people not seeking the healthcare they probably should have, because of fear of going to hospital and going to clinics, but dying of other causes than COVID, and how much of it is food insecurity, which is always such a nice way of saying starving. It will be a combination of all those and additional factors, and the levels of despair and the mental health toll that Prof. Mokoena alluded to is significant in that. So the only way of knowing how much of that is COVID related or not, in the absence of more tests, is to look very closely at the pattern of how those excess deaths move through space and time. And what we saw there was that in every single, not only province, but district where COVID cases increased, the excess deaths also increased. So that is over and above what you'd expect if the effect was more or less uniform because of the lockdown, or perhaps slowly increasing over time as mental health issues increased and chronic medicines weren't taken and that accumulated. So that is quite an interesting aspect that made us trust those numbers enough to add some of those into, or a certain percentage of those into our mortality predictions. So as I said, this is now from our latest update of the model, which will hopefully be actually published in the next weeks. Don't take my word for it. It's somewhat out of our hands, but that looks like we'll be sitting at 36,000, around about 36,000 deaths. That would include 80% of the projected or of the estimated excess deaths. So that's actually quite a lot. By the end of the year, we hope that, so it looks like at the beginning of November, we will, there will be very, very few additional deaths at least added to that curve. And only 15,000 of those will be from hospital. And that is exactly what you say. So very few people made it into hospital in terms of, so especially those who then went on to unfortunately die. And that is for a number of reasons, only one of which is a capacity constraint. I think a lot of it, as Prof. Mokoena said, is also to do with people, not being always as rational as we thought there would be, or having other reasons for their behavior applied to them that we didn't foresee. For example, not wanting to have their sick beloved ones die without their family around it, which I think is a perfectly fair way of thinking. It just really then despairs us because we think those people would have still had a small chance of receiving care and perhaps doing better when in hospital. But I think those are all of those are good reasons why we saw a lot of deaths outside of hospital. We will never know with absolute certainty. We will always have to use models to retrospectively assume how many of those should have been added to the death toll. But in the end, for better or worse, we might be sitting at those numbers, or quite close to those numbers initially predicted.
Prof. Madi, if I can go back to you just about something that you said, that we must aim for a transmission rate of under 5%. Can you explain how do we get there?
Yeah, so it's not a transmission rate, it's a positivity rate of
positivity
those
rate,
that have been done. It's less than 5%.
Yeah.
And it's all about the breaking the chain of transmission of the virus. And there's different reasons as to why the epidemic is waning in South Africa, why this particular wave is waning. Part of which might relate to the non-pharmaceutical intervention, some of the restrictions in terms of mass gatherings. But another important component, and this is a hypothesis that we're currently testing, is whether one of the big questions that we face is that, as an example, in Soweto and in the Western Cape, roughly about 35 to 40% of the population might well have been infected with this virus, but that hasn't translated into huge number of people developing severe COVID illness, into huge numbers of people dying from COVID. And what is the reason for that? Despite a high force of infection, which itself probably could lend itself to sort of community immunity or herd immunity, where that's because people become immune, there's a break in terms of the chain of transmission of the virus. What's the reason for that? And one of the things that we're exploring currently, and there is some data to support this from other experiments, is that exposure to the common cold coronaviruses, which are viruses that circulate commonly throughout the world and probably even more intensely in highly densely populated areas, that sort of exposure might actually be inducing an immune response, which eventually actually provides cross-protection, at least against developing severe disease. So people still become infected, but they're actually protected in terms of developing severe disease because that underlying immunity that's been induced because of the other common cold coronaviruses is somehow lending a hand in terms of protecting people. So that is a hypothesis that we're currently testing. In high-income countries, as an example, when they've gone back to blood samples from 2019, before SARS coronavirus started to circulate, they showed that as many as 20 to 40% of people actually had this sort of underlying cross-protective immunity because of past exposure. And so I think that's a really interesting part. That's something that we, as I mentioned, we're currently experimenting with to see whether it does actually hold true in South Africa to explain the way this particular pandemic has evolved.
Okay, and thank you for that, Prof. Prof. Mokoena, as Prof. Mahdi said about the non-pharmaceutical interventions like mask wearing. I mean, we're going to have to change our behavior now and aspects, critical aspects of our culture in order to get to a rate of below 5% positivity rate in the testing. So how do you change a culture? We've had to learn to do so many things like wear masks, social distance, not go to funerals. Physical contact's also a problem. I mean, these are difficult to achieve. How do you fix it?
Several years ago, I asked my grandmother about what she remembered about World War II. And I was surprised by her answer. She said, that was the first time we had yellow maize. And I thought, what? You didn't mention Hitler? You didn't mention war? It was just, that was the first time we had yellow maize. And I was quite surprised by that, precisely because sometimes what we think is a unbelievable social change, for many people may actually be a small difference in terms of the color of their maize. So it's really about thinking, which scale are we talking about? For many people in the world is not a felt presence. So most people in the world don't have what we may call a global consciousness. So as much as we may imagine it's true, not everybody in the world knows who Donald Trump is, or not everybody in the world knows where South Africa is. And so quite a lot of the times, what we imagine is a global event may actually be quite a localized event. And so I think quite a lot of the changes that have to happen have to be translated into quite meaningful local idioms. So for example, when the CDC first started talking about people wearing masks, my first concern was, how do you imagine that everyone in the world can have surgical masks? I mean, how are you going to go around the world and distribute several billion masks? And in South Africa, what was interesting was that almost immediately the directives that were issued allowed people to create their own masks, gave them specifications of how thick the mask should be or how thin the mask should be. And so those are the things that are actually the change. It's not the mask wearing, it's the fact that you have to translate everything into a kind of local idiom so that what is a global event can actually make.
I think Prof. Mokoena's dropped off. Are you there, Prof. Mokoena? Okay. All right. So if we can, we'll go back to that. But if we can proceed to round 3. So we're all expecting another wave of the virus, but as we all set about trying to plan December holidays and such very important things, we don't know when it's going to hit, and so let's get some advice. Prof. Myrath, so we're expecting a next wave. When do you think that that's going to hit? Sorry.
What I didn't mention before is that, especially as part of the COVID modeling consortium, we don't gaze into crystal balls, and that's really, really important. We are hugely aware of the uncertainty that is being created by having to assume almost everything. you will not hear a date from us, and it would actually be unprofessional to be putting down dates at this stage. We don't know. We as modelers, and together with everyone who's dealing with this at the moment worldwide, can decipher some of the factors that will influence how quickly and how high how quickly we'll see a resurgence, and then how high it will be, and also whether at all. Between us, we probably all believe in our heart of hearts that we'll see a resurgence, and that this will be with us for a couple of years. But none of us can be certain of even there being a resurgence. It depends on how much immunity, like as Prof. Mahdi already alluded to, a single infection leaves behind. Whether that immunity then actually conveys protection, even that is unclear. How that is spread, if we have enough immunity in all places, blanket across the country, all like the states only had really high epidemics in a number of states, and now have, instead of a second wave proper, a lot of first waves just in US states that didn't have a first wave, in April and March. So it also, however, just like the first time around, depends a lot on human behavior. And I think that is actually one of the fault lines that, again, we can control and we need to be very vigilant about. And that is to not slack off with the non-pharmaceutical interventions, to still maintain distance as much as possible, to keep wearing proudly, or very proudly, South African mask. As you might be aware, the WHO changed their recommendations very much based on work by our own ministerial advisory committee on how good even 3-layered cloth masks would be going. And I'm originally from Germany. I'm spotting these pictures of people wearing Schwäche in their faces all over Germany. So look at that. So there's an export, definitely. But so we will have to continue doing all that. Most of us will not continue to be able to work from home, and we will have to get used to a whole new set of routines that allow us to do that safely. Same for the children in school, same for transport, public transport, etc. Now is not a good time to be slacking off in any of those. As we said before, it's in everyone's hands, and it will continue to be in everyone's hands. And I think what's really important is also to bear in mind that even if we don't have a second and onward waves of COVID cases, we will be hit with a second wave or with a large wave of chronic, sequelae of infection, of people needing assistance, of mental health issues, of that despair that is being unleashed now that perhaps the most immediate pressures are no longer there. And that is something that I, as a modeler, still think we need to quantify, just so we can get our systems ready for that wave, in addition to additional COVID case waves.
Prof. Mahdi, what are you seeing? What are you thinking in terms of, and should we go out and buy plane tickets in December?
Well, like Zina, I don't have a crystal ball either. But I think there's 4 factors, and I think the 4 key factors, which sort of Gesine has alluded to. The first is the number of people that have, the percentage of the population that have been infected this time around, which is important. The second issue is the immunity that's induced with that infection and the durability of that immunity, which is probably an unknown. But most of the indicators based on other coronaviruses is that immunity lasts for at least 2 to 3 years. Then the other issue, and I think this is something that we haven't emphasized enough, but there is some literature now which shows there might be a factor, is the climatic conditions. And it might well be that this virus, like many other coronaviruses and other respiratory viruses, is much more efficient in terms of its transmission during the cooler periods of the year. And then fourth but not least, in terms of what will influence when this next wave will come forward, is again related to the issue of the non-pharmaceutical interventions and adherence to that. And I'm pretty much convinced that come December holidays, people are going to become more complacent about these non-pharmaceutical interventions. Unfortunately, we're going to see mass gatherings. And if you were to ask me to guess when the next wave is going to happen, my expectation right now would be around about February, March of next year. And it's really driven because of what's going to be happening in society more broadly. But I think importantly, even if we have the next wave, in all likelihood, the next wave is going to be of a lesser magnitude than this time around. The number of people that are going to develop severe COVID-19, the number of people that will die, probably will be much less than what it was this time around.
And how is the Oxford University vaccine trial going, Prof? We know that it takes years to develop a vaccine, and how quickly do you think we are going to be able to get it done?
Right, so unfortunately for the study, fortunately for the country, the dampening of this particular epidemic has actually prolonged the time period by which we'll be able to get an answer as to whether the vaccine works or not. Because the way these vaccine studies are designed is that you need to get X number of people or a certain number of people to develop COVID-19 before you can do the analysis. Initially, we were projecting that would occur in November. We now project it will probably only occur around about February or March next year, because it's going to take longer for people to develop COVID-19 because there's very little virus that's circulating in the country. But the study itself is going well. We almost completed enrollment into the Oxford vaccine study, and we're currently enrolling into the Novavax vaccine study. So there's two studies that are running in parallel. The recruitment of the studies, there's been no shortage of volunteers without any question, which is great. But fortunately for the country, unfortunately for the study, we're going to be a bit delayed in terms of when we'll get an answer, at least in South Africa, as to whether the vaccine works. What we likely will do is combine data together with Brazil and the study that's been done in the United Kingdom, which will still allow us possibly to get an earlier readout, hopefully by November of this year still, as to whether the vaccine is efficacious. But we won't have South African specific efficacy data at that point.
Okay, thank you for that. Dr. Crisp, how is the Department of Health planning for the next wave? What do we, and how bad do you think have to get before we get locked down again?
Well, I also don't have a crystal ball. Like the colleagues, we're all going to play it safe on this one. But the question is what we do to strengthen our health system. We've heard already that we knew before this pandemic hit us that we had huge holes in our health system, and that we have a very disjointed and uncoordinated health system. It's not necessarily well-resourced. Parts of it are extremely old, bad communication in large parts of the country, and so forth. We were aware of a lot of that, and that's exactly why we've been planning for national health insurance, so that we can use the resources that we have available to us in a far more logical way, that we can coordinate them and make sure that everybody is protected equally and well, and doesn't, that we don't have to rely on our ability to finally find money when we finally get sick. So that is really where the focus has to shift to as fast as possible. How do we accelerate the improvement of our health system? Now, there are many things that need to happen. We know that we need to strengthen the public health system and improve the quality. And we've heard examples of extremely poor quality in the public system. But what you don't hear about is the extremely good quality that have helped people to survive during this period. We need to learn from those centers and roll that out. We've also learned that the private sector is extremely vulnerable. We knew before the COVID hit us that there were problems from the health market inquiry telling us about the waste in the system, inefficiencies, all kinds of other inequity in the way that people access the private healthcare system. And what we learned is that once the epidemic hit, the private hospitals more or less shut down, many GPs' rooms closed, and that entire sector was left without income. People are still fearful of going to services. There have been infections in that environment. So there's not a single part of our health system that doesn't need a rethink. And we've heard some of the problem with access to data inside the public sector. We have problems coordinating and the validity of that data. We need to step up our interoperability of our systems, the portability of how our patients are able to move, proper designated referral systems, and what we call a proactive or strategic purchasing, where we make sure that where we know there's a burden of disease in the community, and Prof. Meyer-Rath referred to this, this is one of the bigger concerns. It's not is the epidemic coming back. It's what epidemics have we now created by people being fearful of coming to the system and not getting their diabetic medication, not getting their mental health medication, et cetera, et cetera, et cetera. So all the health departments, and we are a national department and 9 provincial departments, plus the private sector, everybody is acutely aware that there are legion patients in the community that need care at the moment, and we need to be more vigilant than ever. But I want to emphasize what the colleagues have said. Now is not the time to be complacent and let down and start planning, holidays and parties and so forth. That is what will create the next wave. And we really need to take responsibility as individuals for our own health as far as we possibly can. Taking our medications, going for our appointments. No slacking off on masks, no slacking off on washing hands, etc., etc. Thanks.
Prof. Mokoena, so how do you think future historians are going to look back at, our world has changed. Governments can change. I mean, the US election at the moment has been pretty much being fought around COVID-19. So what do you think future South African historians will say about the impact that COVID-19 has had on the country?
Well, unlike my other colleagues, I'm going to create a crystal ball. So instead of saying that, I'm going to create one now. History is very strange in the sense that history is almost like an accounting of disaster. So one of the unfair things about history is that it's not going to tell you how well things actually were managed. History will always tell you how disastrous everything was, because history is really about telling you how many people died, how many people were infected. I don't know how many of you have been to the Johns Hopkins website, that shows you the global figures, or any of those kinds of quantifications. I mean, you just see red dots all over the world. And I think from a historian's perspective, that's what people in the future may end up obsessing about those red dots that essentially covered the world. But again, at a more micro level, I think what happens is almost like the narrative of a nation changes. So in the case of South Africa, it's not so much how history is going to judge us, it's how we are going to change the narrative of our nation based on the pandemic. Number one, it becomes more difficult to trust politicians. So a lot of people, the first thing that happens is that they rewrite the story of the country in terms of, oh yeah, corruption only started during the COVID pandemic, or civil servants became untrustworthy only during the COVID. So it's more about how you narrate the nation and how that changes when there is a catastrophic event like this one. But thinking a few years back, I don't know how many of you remember the veld fires that happened in Cape Town in the early parts of the 2000s. I was still a student at the time at UCT. And I can remember looking at the mountain, literally it looked like lava was sort of cascading down the mountain. That's how severe the fires were. And I remember back then thinking, this is how the world is actually going to be. So one of the things that is actually going to change from a historical perspective is that we are almost always going to have to think about catastrophe. And we have to come up with almost like a politics of catastrophe, or even a new language for thinking about catastrophe, because we're going to lose a lot of human beings, but also things like property become a little bit less meaningless. I mean, most people haven't driven during the lockdown. Most people didn't drive their cars for 5 months. And so many people started looking at their cars like, what am I actually doing with the car? Because now it's sitting here and it's not doing anything. So even our definition of our basic life materials that we use, the food we eat, the water we drink, the clothes we wear, it's all going to be redefined. But I think the most worrying part is how we re-narrate the narrative of our country, in which then catastrophe becomes part of everyday language. And I think that's what changes from a historian's perspective, is how it is that people almost will change the way that they talk. So what was once pleasant becomes unpleasant. What was once unpleasant becomes pleasant. Those kinds of black and white, all of those things sort of are changed around when people are faced with a catastrophic event. So, going on holiday, what once seemed like a necessity, now people will say, maybe not. Or even staying at home. So many of us used to fantasize about how we would be so much better workers if we could stay at home and not have to get dressed and not have to go to the office. But many of us are finding it's exactly the other way around. We've been at home and we're like, maybe I should go to the office.
It's like, really don't feel like being here right now. Prof, we just have to move on to some questions from our viewers. Prof. Madi, can I direct this to you? Pat Sidley writes, the BBC reported a postulation that the reason why Africa's pandemic, including ours, has not been as dreadful as initially thought may be due to poverty and factors within that are not as yet known. Is that utterly outrageous, or is there some truth to it?
It depends how you express that poverty. I think what you might be alluding to is what I was sort of trying to suggest earlier, and that is a high density of population and the limited ability to adhere to physical distancing, etc. in the past has possibly exposed to people to a higher greater risk of being infected with this common cold coronavirus. And there's probably some immunity that's been induced by this common cold coronaviruses that's actually protecting against developing severe disease after people are infected with the SARS coronavirus too. So that is sort of the possible linkage in terms of overcrowded living conditions, paradoxically assisting in terms of fighting off severe disease from COVID-19. And I think that's what you might be alluding to. Poverty is not a good thing. Poverty kills people. It causes people to die because of hunger. But when it comes to immunity against different diseases, there are differences in different populations based on the type of exposure. And it wouldn't be unique to SARS coronavirus 2. This is the same thing that we see for a number of other pathogens.
Dr. Crisp, Jill Murray asks for your comments, please, on the current daily number of tests. She thinks that they appear to be too low to have a handle on the direction of the epidemic. What are your thoughts on that?
Yeah, well, I think Prof. Madi sort of covered this earlier, but we can emphasize it a bit and say the more tests you do, the better. But it is, first of all, it's an affordability issue. Secondly, it's a question of who are you targeting when you're taking those tests, and then what's your positivity rate. If you are picking up a very low positivity rate, no matter where you are taking those tests, that is a good indicator that you don't need to be spending a huge amount of money on doing more tests. Whereas when you're picking up a higher positivity rate, you want to be a bit selective about where you target taking the tests from, because there may be subsets of the population who are higher at risk. So during the epidemic, the policy has changed from time to time from the Ministerial Advisory Committee. And for instance, we want to protect our health workers, because if we don't have them at the healthy and well, then we don't have anyone to look after our patients. So at a period, they were the prime concern. And then also a prime concern is people with comorbidities. But when you are dealing with massive positivity rate, then you really do need to up your numbers. So whether we have the right numbers now or the wrong numbers, whether we are spending enough or not spending enough, I think perhaps others more qualified to comment on that than I, but that's the general gist of it.
Thank you very much. Another one for Prof. Madi. Susan Gordon wants to know, what about the theory that South African people's TB vaccination as children has protected us from COVID-19? Anything in that?
Yeah, I think unlikely. I think there's a study that's been recently, in fact, it's in preprint, so it means it's been peer reviewed. I think it's from Switzerland, which has basically tested that hypothesis, and they've shown that previous BCG vaccination in infancy doesn't protect against COVID-19. So I don't think that's the reason why we've experienced what we've experienced in Africa or in South Africa for that matter.
Great. And I think that concludes our questions. So I am going to, Tanya, you know that there are no crystal balls. This is a crystal ball free zone. And except for Prof. Mokoena, of course. Yes. So Tanya is going to take you through the final round. Over to you, Tanya.
Thanks, Nikki. So we don't have crystal balls apart from Prof. Mokoena, but maybe we can do this as a bit of a lightning round in the interest of time. Prof. Meyer-Roth, so we're already seeing a second wave in Europe. What are the variables that will determine what happens in South Africa, and what are you foreseeing?
I think what's interesting about some of those resurgences in Europe is that they are, especially in young people who went out, went on summer holidays, for who this didn't become an unpleasant thought. The party came back. So what's being seen there is that the disease severity is actually quite a lot less now. That might have been a good idea in order to increase exposure and zero prevalence in those populations, but it also is an experiment on the back of extremely well-capacitated health systems. I think a main message needs to be in the next months. We don't do summer holidays at the beach without ever interacting with our elderly families. Quite the opposite. We go to the beach and then we go home and have the big meal. And we do this for days on end. If we need to make holiday plans, then let's keep protecting the elderly. That is the most important thing, both the elderly and especially people with diabetes, which often is, of course, undiagnosed. Yes. I think that is one of the main issues to keep perhaps not the second wave flat, but the mortality under that second wave as flat as we possibly can.
Thank you so much. So Dr. Crisp, even before the pandemic hit, NHI was something everybody was talking about for quite a while. What impact has the virus had on the the NHI and the onset of the NHI?
Well, I think what it's done is, well, a number of things. One is it stopped the parliamentary process because it wasn't possible to continue with the consultation. And the parliament is going to need to pick that up and find new ways to do it using virtual meetings and so forth. So in terms of a delay in the passing of the legislation and the engagement with the population, that was the first impact. The second one is we've learned we need an NHI more than we ever needed it before. And we really need to think very, very clearly that it's not a reason not to implement the NHI. We spend enough on healthcare in the country, we just spend it really badly, and we don't coordinate what we're doing because we have too many disjointed and disconnected parts of our health service. We've also learned that if you spend your effort in the primary healthcare environment and you invest in poor people's health, that protects everybody's health. We also know that this will not be the last epidemic we're going to get. We know that there are vulnerable people, and vulnerable people will be exposed to other viruses. So even if there's more waves of this particular pandemic, there will be more to come. And whether they come soon or whether they come later, we need a health system that's resilient, that is able to look after everybody and is responsive. So the NHI is not on the back burner. On the contrary, now that we've dealt with the urgent part of COVID and colleagues are still dealing with the clinical implications, those of us who have been working on getting the administration and machinery in place for the NHI are redoubling our efforts and learning whatever we can from COVID to step up the pace of implementing NHI. Thanks.
Great, thank you. Prof. Maddy, maybe you can just answer this in a nutshell. So, we can say a second wave is coming, but as human beings, we possibly have some agency over how enormous that wave is. Is it going to be a tsunami or is it going to be a smaller wave? You did touch on this earlier, but what can we as human beings do to make sure that the second wave is as small as possible?
So I think what Nicholas sort of mentioned is, and Gesina mentioned, is all about adherence to those non-pharmaceutical interventions and not becoming complacent about it. I think the experience in Europe is somewhat different from the experience that we're likely to have in South Africa if there is a next wave. And the reason for that, like I mentioned earlier, is my estimate is that the percentage of the population that was infected this time around in South Africa, especially in the major urban metros, was much, much higher than what was experienced in many European countries during their first outbreak. So I think we sort of will see a different trajectory, and in all likelihood, and I hope so, is that the second wave, when it does arise, will be of a lesser magnitude.
Great, thank you so much. Prof. Mokoena, are you with us still? Prof. Mokoena? Okay, she seems to have dropped off. I wanted to ask her about how our political landscape would have changed, but unfortunately, I think she's busy looking into her crystal ball. So I'm just going to go over now to Nikki for the closing.
Okay, thank you so much. I'd like to say a big fat thank you, like my waistline from the lockdown, to all the wonderful panelists who have been with us today. And thanks for letting us know what to expect and then how we can plan our lives. So our key takeouts are no December holidays, people. Be careful. If you go on holiday, don't go see your grandparents. Not a good idea. And absolutely no slacking off on the washing of hands and the wearing of masks. So thank you to all of you who are with us today. The recorded discussion will be made available in a thank you mailer that will be sent out after the discussion. So please keep an eye out for that. And yeah, keep safe. Have a good mask wearing, hand washing weekend.